Good evening, everyone, and welcome. Thank you for joining us this evening. Before I go into the introductions, I'd just like, on behalf of all of us, to acknowledge the death of Her Majesty Queen Elizabeth II. During her life, the Queen was an example to all of us in so many ways, but as several of us discussed before this evening, one of those ways was that she really embodied the importance of the special human value of kindness. We will remember her with gratitude and fondness. I'd also wish to acknowledge the traditional custodians of the land on which we all live, work, and we meet today. May the values, knowledge, and wisdom of all of our ancestors be with us as we walk through life. Namakai kotua katoa koti tumako, kapai ki katoa tanui webinar. In New Zealand, this is Te Reo Maori Week, and I have just greeted you with welcome everyone, and we hope you enjoy this evening's webinar, Kindness, the Business End of Healthcare. It's my absolute pleasure tonight to share the chairing of this webinar with Irving Taylor. Irving is on screen. Welcome, Irving. And he is the Emeritus Professor of Surgery at University College London, and he's also the chair of the Senior Fellows Society of the Royal College of Surgeons of England. We're very indebted to the RCSE for their support and assistance in setting up our own Senior Surgeon Section webinar. Irving, thank you so much for joining us tonight. I'd like, Irving, if I may, to please ask you to introduce our very special guest and speaker for this, our inaugural RACS Senior Surgeons webinar, Bob Claber. Thank you, Irving.
Well, thank you very much indeed, Anne. And first of all, I'd like to thank both yourself, Anne, and indeed Alan, for kindly inviting me to participate in this webinar. I guess wearing my hat as chair of the Senior Fellow Society of the Royal College of Surgeons. I agree with you entirely. I think it is particularly relevant in this week when the Queen sadly passed away, that we now have a webinar devoted to kindness. I actually met the Queen on 2 occasions, and from that experience and from many other accounts, the Queen herself can be regarded as a very epitome of kindness, of compassion, and indeed consideration to whomever she met. I think it is very appropriate indeed to dedicate this session to her memory. And talking of kindness, there can be no better person to discuss the virtue of kindness in healthcare than our speaker this evening. Or at least this evening for you, but it's the morning for us. Bob Claber is a consultant paediatrician and is Director of Strategy, Research and Innovation at Imperial College NHS Trust. He trained as an educationalist alongside his postgraduate paediatric training and has a strong interest in quality improvement and in leadership development. Bob is also a member of the NHS Assembly. In 2015, he set up a team to create a culture of continuous quality improvement across Imperial College Healthcare. And as Deputy Medical Director, has led work on the development and implementation of the Trust's new organisation strategy. I guess we all know it is often so easy to forget about the importance of kindness in the highly technical business of healthcare delivery. And this is a topic which Bob has focused on in much of his writing. So thanks, Bob, for agreeing to speak. You've already spoken at our Senior Fellow Society and it was a huge success. And it's very good to meet up again and hear your talk on kindness. So Bob, thank you very much indeed. And I really, and I'm sure we all do, look forward immensely to your talk. Thank you.
Thanks so much, Irving and Anne and Alan, and just for your really, really lovely words. And I'm sort of full of full of thought and I guess sort of memories as well. And I think, as you say, a really to be exploring this topic together and thinking about everything that the Queen stood for is a really thoughtful way of doing things. I think above all, the thing I think about is the Queen understood this thing that people are just people, and in a world that is struggling and creaking in many ways, whether it's around climate or war or all sorts of other difficult things. It's just absolutely wonderful to be with you genuinely across the globe. So I'm sat here in North London, having had a couple of work calls already, snuck out to come and spend an hour with you, which is just such a privilege. And I think everything we can do to connect, to share, to learn with and from each other is absolutely key. So I'm absolutely thrilled to be here with you, and I hope that we can have a bit of fun together, we can learn a bit together, and hopefully we can all walk away from this with some sort of greater clarity of thought about what I think is a really, really fundamentally important issue for us in healthcare when we look at what's going on forward. So I'm going to talk to you about leadership, really leading for kindness in healthcare, but this key piece about things being the business end of healthcare. Those of you, I do a little occasional bit on social media. You Twitter experts are out there. You can find me on @BobClaver. And I've got my email address later on in the talk, so please do get in touch. I'm really keen that we connect around this. That feels very key. So I'm just going to get this moving. Here we go. So I think part of this is about telling a story, and when you look at storytelling across the globe, my learning about storytelling has come from a few places, but probably more than anywhere, this rather wonderful man who's called Marshall Gantz, and some of you will have come across him, G-A-N-Z, Marshall Gantz, who's a professor at Harvard, and he has written a lot and talked a lot about something called public narrative, really influential on people like Barack Obama. He did a huge amount of work in the civil rights movement in the 60s. And what Marshall Gantz says in terms of telling a good story is you've got to cover 3 dimensions. You need to focus on self, on us, and now. Now, Alan gave me a very lovely introduction with the biography that sort of gently made me blush, and I sort of think I don't really recognise half of that. I'm not very interested in what I've done and what I've achieved and things. Okay, you know, proud maybe in a quiet moment, but actually what's much more important on self is, what do I stand for? What are the things that really matter to me? And I'm going to share a little bit of that with you. And then us is about, how does that connect with you as an audience? Now, you know, you're many thousands miles away and we're going through a virtual means, and that can be harder to connect than if you're in person, but you still absolutely can connect through stories. And the story of now is about action, is about urgency. And I think we have a real urgent need to really focus on this in a really big way. So self, us, now, that's the framing of my story that I'm going to tell you. So I was up in Glasgow 3.5 years ago, sat at a big conference, a conference run by the British Medical Journal and the Institute for Healthcare Improvement on the east coast of the States. And I was there. It's a conference I've been to many times. It's probably my sort of main quality improvement way of connecting with, particularly with a European focus, with friends and colleagues who are focused on this agenda. And I was listening to 2 absolute sort of healthcare legends, Don Berwick, who many of you will know, who is another paediatrician, but one of considerably more esteem than me. And Don has become a wonderful friend, working on the east coast of the States. Don's founded the Institute for Healthcare Improvement, and he was doing a talk with Maureen Viziano, who went on to become the chief exec after him. So Don, a paediatrician, Maureen, a nurse by background, went on to go and lead healthcare. You know, Don was running the bulk of US healthcare at one point. And they were talking about all sorts of things. And they had this one slide up about kindness. And it was based on some work from a chap called Len Berry. And I'll touch on this a little bit later, the detail of Len's work. And I was sitting there thinking about this. and thinking, and I come from a medical family, and I think a key part of my upbringing was sort of, be kind, be helpful. So I've always bought into the idea that kindness and compassion and empathy are important. In fact, are very important. But I'd always framed them as being, I know it's really soft and fluffy, but it's important. And sitting there 3.5 years ago in this conference hall in Glasgow, I had this moment where I just thought, I've got this completely wrong. It's completely the business end of healthcare. It's where we need to start. So yes, balancing the books are really important, and making sure we've got the money sorted out and the governance sorted out and all of those things that seem to dominate everything we do. But they're a tail for us to get right. They're not the dog. The key piece for us is you have to start with kindness and compassion. And certainly speaking with a deep depth of knowledge of their healthcare system in England, but actually, as I've started to explore, discovering that this is a trend across the world, as our healthcare systems have become fundamentally unkind. My great friend Victor Montori, talking about, with his work around the patient revolution, talking about the industrialization of healthcare. So we focused on the sort of technological industrialization, and we moved away from healthcare being focused on care, on humanity, on kindness, on compassion. And that's to our real detriment. And when you look at some of the really significant workforce issues we've got, we're in a terrible state in the NHS in England around our workforce, or across the UK. And indeed, you look globally, there are many issues around that. But right at its heart is healthcare has become an unkind place to work. And you talk to young people who are starting their careers, and pretty quickly they can become disillusioned by the way we treat each other. This is crazy stuff. There's a whole bunch of people who have gone into it to demonstrate care. We people who've got a disproportionate bias towards working in something in a caring profession. Yet there's an intrinsic unkindness in the way things have been set up, and that needs to change. And that's what this mission is really all about. So this conversation is really about how we improve quality. So back to my friend Don, and 21 years ago, the Institute of Medicine, Don and colleague Paul Batalden and others were really the first people who started to describe quality, leaning on some of the work that had been done in manufacturing, and going back to Deming and others. And Don and colleagues talked about these 6 domains of quality, around effectiveness of care, around making sure care is patient-centered, care being timely, being safe, being efficient, and being equitable. And this equity piece, really across the globe, but we're seeing it in the UK in a very big way, has been having a big floodlight shone on it. We've put that in the too difficult box for 20 years, and really since COVID, the cat is out of the bag, and there's a big focus on equity, which is long overdue and actually really exciting, and something for us to be very hopeful about. But we have some serious issues that we need to climb. And kindness is going to be a really key tool and weapon and approach as we try and do that. So there'll be loads of you on the call who like theories and understanding logic and how that might work. There'll be others who really want to see some evidence, and there'll be others who are sort of itching to sort of get stuck in and try some sort of practical things. So I'm going to try and do a little bit of a mix of these things and give you a few little references as well, as a bit of a tour of really people I've been learning from. And I'm a massive believer in Irvin's lovely introduction, talked about me being an educationalist. I think, one of the few things I'm any good at is learning, and I have a real passion for continuously learning. It's what Maureen Bixiano calls curiosity, and it's a useful thing to have. So one of the wonderful people I've met is John Ballot, and John and his partner Penny Campling wrote this fantastic book about a decade ago, and there's a second edition that came out about a year ago, it's slightly updated, but at its heart it's a very small book, and they really described this theory that kinship promotes kindness, and that directs an attentiveness which enables people to tune into each other's needs. That builds trust, it generates a therapeutic alliance, and that leads to better outcomes. And whether you're talking about a clinician-patient relationship or a clinician and family relationship, when you're thinking about some of the families who you will all be, the families of the patients who you're looking after, or whether it's a colleague-to-colleague relationship, this theory, this cycle, seems to be very intuitive and makes sense, and others have come along and tested this out and demonstrated some of the outcomes around it. So Intelligent Kindness, John Ballot, Penny Campling, really worth a read. I really love their work. I think lots to learn from here. This, I think, is a stunning piece of work. It's a really easy read, 45-minute read, from a wonderful organisation based up in Scotland called the Carnegie UK Trust. And Julia Unwin, who's a really sort of senior, experienced, I think she will have been in her 50s when she went and took this Carnegie Fellow. It's a great, it's sort of like a sabbatical, it sounds like. If ever I could get my hands on this sort of role for a year, I'd love it. She went and studied kindness, emotions, and human relationships within public policy. So not just focused on healthcare, but very applicable to. And essentially, this was written about 2.5 years ago. And what she described is these two lexicons. And I actually have this, if I was talking to you from work where I'm headed in at St Mary, I have this on my wall behind my shoulder. I find it so useful to bring into conversation. So what she said, she described public policy in the UK as being really dominated by this rational lexicon. So what happened 10, 15 years ago, we had a number of scandals in healthcare around, people focusing too much on finance and patients being harmed and things. So big investigations and new policies and laws put in place. And essentially the focus became on, the motive was to try and make things more balanced and fair and safe and transparent. And we had these tools were put in, lots of scrutiny, the role of a regulator, lots of focus on value for money, lots of targets put in around our emergency departments, around waiting lists, this sort of thirst and demand for evidence and data and accountability. And these are all good things and absolutely have their role, and led to lots of systems and processes being put in place and professional codes. But the risks around this is it can become very sort of arid and sterile, and people start gaming targets and people become detached from the purpose of the work that they're doing, and you start to lose trust. Now, the relational lexicon is all about building connections, is about supporting individuals to connect and build trust. It's about hope, it's about personal change and development. And some of the tools that you might use around that are a focus on well-being, on friendship. In a way, what are you gathering together as senior fellows? You start to play into some of this piece about the network. Intuition, warmth, the role of storytelling I've touched on before. And the outcomes here are about building relationships and building trust. And within that, you can absolutely still have challenge. Now, there are definitely some risks around it. It can be framed as a very sort of populist approach. It can be harder to measure. Maybe you move into issues of equity around favoritism. So what Julia Unwin argued is you need to have both of these. You need to have a balance. And we've definitely had a situation where the rational lexicon has really dominated. And what we're trying to do, certainly in the National Health Service in England, is get this balance around these two. So we can pick that up. I've seen somebody raise their hand. If you've got any questions and things, please put them in the chat. And in 20 minutes or so, we'll be through this, and then we can open those up and do things. So questions on into the chat, and we'll keep an eye out for them in a minute. I mentioned Len Berry earlier, and Len's an absolutely wonderful man who works in oncology, and he has evidenced the role of kindness in improving outcomes in cancer patients. So kinder care leads to better outcomes in cancer patients. So great, that's helpful. Now, the bit that I want to articulate here is, what does Len Berry and team mean about kindness? What do you mean by kind acts? How do you codify them? How could any of us lot listening go and start to copy and replicate some of these acts? And I absolutely love this. And the timing for me of doing this talk to you is fantastic, because tomorrow morning I'm back on the children's wards for the long weekend as the attending consultant. And I'm going to remind myself again of these 6 because they are absolutely wonderful. And I just love the language in them. So the first one, deep listening. But think about when you listen to people, your loved ones at home, or your friends, or colleagues, or patients and things. Do you always really deeply listen? Are you sometimes distracted? The idea that you can listen to somebody and be sending an email, all of these sort of things. So this piece about really deep listening with fascination. People like Nancy Klein have talked about this rather beautifully. The second bit about really clear empathy, really trying to put yourself in people's shoes, working really hard to do it, or get towards putting yourself in people's shoes. I sort of believe you can't quite do it. You can't quite experience what people are having. We're, thinking about the extraordinarily difficult circumstances that many of the patients and families who we look after, and indeed sometimes colleagues as well. I love this language, generous acts of discretionary efforts that go beyond what patients and families expect. Generous acts of discretionary, those really small things about popping back to go and see people, just making that extra effort. Timely care that reduces stress and anxiety. I'll give you one of my favorite surgical examples, which is there's wonderful surgeons, and there'll be people on the call who will do this all the time. Surgeons who will, just got end of an operation, and people are just closing up, and the surgeon will phone the mum or dad or the daughter or the partner, the relative of the patient who's back up on the ward, waiting for them for a 20-second phone call to say, look, just phoning to let you know, looks like everything's been all good. Your loved one's going to go to recovery for a couple of hours and be back on the ward. I've got to finish my list off, but at the end of the day, I'll come and pop up and have a more detailed chat. 20-second call. What that does to people, I'm a physician who works on a ward, so I'm not in theatre, but I see those families on a children's ward where the empty bed space, because the bed is, and their son or daughter is down in theatre, and I see the anxiety, and that phone call just calms everybody down in the most beautiful way, and that takes 20 seconds, and that is what we're talking about kind care, timely care that reduces stress and anxiety. Listen to this language, gentle honesty in discussions and conversation. Okay, healthcare 20 years ago, 25 years ago, when I was in the early days of learning as a student and a junior doctor, we were taught to be very careful about what we said. That's only 20, 25 years ago. Thankfully, that's really opening up, but this sort of spectre of, can you be really honest? We have to be straightforward and honest to people, and we have to make sure that our learners in our healthcare system really understand that. And this lovely piece about thoughtful support for families and carers. So Len Berry's work, worth looking up. I really am a massive fan of that. Compassionate leadership really links into this in a big way. And I have fantastic friends and colleagues at the King's Fund, which lots of you will know of. And do look them up. They're a think tank, a UK-based think tank, based in the centre of London, and they've got lots of fantastic free resources. And there's a friend and colleague called Michael West there, who spent his career researching teams and what makes successful teams. And he is absolutely fantastic on this topic of compassionate leadership. And there's all sorts of things on YouTube you can find. And he's a brilliant speaker, even on a video. So do look him up. And compassionate leadership, attending, paying attention to staff. There's that listening bit, that Nancy Klein piece, listening with fascination. I just love the language on this. Understanding it. Do we, really work to get a shared understanding of what people we're working with are facing? Empathizing and helping, taking intelligent action to serve or help, really little things. And when we come to the practical bits later, I want to talk through how some tiny little things can make such a difference to people. So compassionate leadership, Michael West's work, well worth looking up. On compassion, this is a book by two Americans, Stephen Trzeciak and Anthony Mazzarelli, lucky enough to meet. This is a bit of a tour de force where they basically went through and dug out the evidence that care makes a difference to outcomes, and it's very readable and really sort of energizing book that if you need any convincing that this is a topic that genuinely leads to better outcomes, please have a look at that. And then the final bit of sort of theory I guess I want to touch on is this crucial piece about psychological safety. And I think for all of you who work, have worked or work in a theatre setting, For me, the ward, the clinic is the sort of key unit here. But this concept of psychological safety is absolutely critical. So firstly, on the right, Amy Edmondson is probably the academic across the globe who's done the most on this, not just in healthcare, but thinking about the workplace. Again, well worth looking up, and this is one of her books. She's got a fantastic book called Teaming as well that really focuses on it. But I want to pick on this Google work. So think about Google. I mean, you know, an extraordinary, brutally commercial company. Okay, let's be straight. Their incentive to do things is to commercially succeed, and they spent a lot of money focused on what makes a high performing team. Why do they want to know that? Because they want their teams to perform as well as possible, so they're as commercially successful as possible. So they put together a big program called Project Aristotle, and it was focused on ethnography and qualitative research. And they spent 2 years, they looked at 180 teams, almost 40,000 employees, and asked the question, you know, our most high performing teams, what's going on? And they came up with these 5 things, but the bottom one, psychological safety, was the biggest by a long way. So first one, impact. Can team members see and feel that their work matters and leads to change? Meaning. So work needs to be personally important to team members. Now, we work in an extraordinary opportunity to be able to get these things right, but so often we don't. Structure and clarity. Do team members have clear roles? And is their work sort of linked, has clear aims and measures and plans, so that they know what they're doing and they can see that as they're doing it, it's making a difference? There's a really important piece about dependability on each other. Do we value the different bits of the jigsaw that each of us can bring? And then this crucial final bit that was the biggest factor by a long, long way, psychological safety. Team members feel safe to take risks and to be vulnerable in front of each other. So let me play this out with my example. So when in the early days of I've been a consultant at St Mary's for 13 odd years. In the early days of doing that, I sort of thought, oh gosh, you know, I must be there for my expert knowledge about pediatrics and how to look after children, and sort of quickly realized that I'll get found out on that. And actually, that's not really what I'm there for, because I'm surrounded by amazing people, fantastic nurses and therapists, brilliant junior doctors who are super aspirational about their careers and learning, these amazing people called parents and young people. So the inherent knowledge and expertise is around that. Actually, my role is one of leadership. How do you create an environment where people feel psychologically safe to absolutely be on their top game, where we're all really listening to those fears and anxieties that a mother or a young person has, where we're listening to the bright ideas that the day one physiotherapist has got? And my example on this is one of medication safety. So when I'm running my ward round, have I truly set things up in a way that the student nurse on their first week of a placement could say, I might be really wrong on this, but I just wonder whether we've already given the medicine to this patient? Can you truly look people in the eye and say, have I lowered the hierarchies? Have I flattened things? Have I opened things up in a way that people could really try and do that? And I think we've got to be really honest around it. And as a 6'3" white man who's a doctor, who's got grey hair, who's an executive, there's lots of reasons why people wouldn't tell me that I'm wrong or I've missed something. So you really have to work very, very proactively around that. So I talk about this quite a lot, think really, really clearly about flattening hierarchies, really actively trying to show humility, to listen. I'm really, really proactive about first names, because I think that's a really useful tool around it. And we could get into a debate about the pros and cons around that. But fundamentally, it's about parking our own ego and our own insecurities around things and creating a space. This is about leadership. And I think it's absolutely critical for our healthcare leaders. And, you know, we have 750 odd consultants at Imperial College Healthcare. Myself, Tim, who's my CEO boss, and I and others feel very strongly, if you're a consultant, that is a leadership role, and it's about creating this fantastic workplace where the brilliant people around you can thrive. So let's move on to leadership, and then we can wrap up into some discussion. So look, listen, this slide gets better with what's going on in the world, in the States, about them trying to get back on the moon. But this is a story many of you will know, but it's such a good story, I'll never get bored of telling it. So 1962, President Kennedy is touring NASA. He's gone to go and see the space station. And it is a time when the Americans are spending an insane amount of money on the space race, really, with the Russians. The percentage of their GDP that they were spending at the peak of this is just incredible numbers. So this was a very big thing. And he goes, the president goes and, you know, meets the space station commander and the astronauts. And then, so the story goes, he's walking down a corridor and bumps into a guy with a broom. What they call in the States a janitor, and in the UK a cleaner. You'll have to tell me what the New Zealand or Australian language for it, but the American language of a janitor. And he said to this janitor, "What are you doing here?" And I guess that sort of polite presidential chit chat, you must get good at that if you're the president of a state. And the cleaner, the janitor, looks at him very straight in the eyes and looks up in the sky and says, "I'm helping put a man on the moon." So you've got the guy with a broom in a corridor who's very clear that he is helping put a man on the moon. And I love that story because it's about mission and purpose and people having meaning in their work. And I look at it and think, okay, cool, the moon, what an amazing, you know, you look at the moon every night, you think, what an amazing mission and purpose. It's very measurable, you either get there or you don't. And then I think, hang on a minute, in healthcare, we've got an even more amazing mission and purpose. Wind back the clock to when you were 14 or 15 or 16 or 17, whatever the age was, and when the penny dropped for you about wanting to have a career in healthcare. What was it? It's this extraordinary mission and purpose and meaning. My wonderful eldest daughter, Izzy, who's 16, who's just starting her A-levels in her sixth form and doing a mixture of sciences and a bit of art, is really in that wonderful space of exploring. Actually pretty sure she wants to go and do medicine and getting excited about this mission and purpose and meaning. And yet we've built these healthcare systems and we've led in a way where we serially and systematically beat that out of people. We cover it in treacle. We put so much noise in the way. So I really think our collective leadership challenge is to reconnect healthcare with its mission and its purpose. And this is absolutely critical. And you know that lovely phrase where you say a picture says 1,000 words. I just want to tell you a little story about this picture. So I said earlier, I do a little bit of stuff on Twitter and things. This is a lovely social media story. I saw this photo come up and I just thought, what a wonderful photo. And get close to your screens and have a look at the faces on these wonderful people. And the internet is extraordinary. So it's connecting all of us across the globe in this call. But it also allows you to find people. So this photo came up within 24 hours and a couple of little messages and notes. I'd found out where this was. So this is a beach in Wales. These lovely people, and the chap at the back is called Richard, and he's 87. And nearer to us is Margaret, who's 84. Adele is a care assistant, and the big guy with a baseball cap the wrong way is called Joe, and he's a volunteer with Ospreys Rugby Club. And I got in touch with a lady called Sharon, who's the care home manager, and she told me all about these people. And these are sea wheelchairs, and any of you who've been to the UK know that the sea is not wildly warm, and you go to Wales, it's even colder. So these people are being wheeled out into the sea to have a really fantastic experience, and I just love their faces. And when you think about what care is all about, I just think this photo is absolutely gorgeous for that. So our leadership challenge, reconnecting healthcare with its mission and its purpose. So a little bit of my thinking around things is, if we really focus on being clear about what our mission is in healthcare, so we've got to cut away lots of the noise and the politics and the focus on money and all of these sorts of things that seem to dominate. What happens is we'll get increased purpose and meaning and actually more joy in work. And there's some really interesting work being done across the globe around that. And if we lead for a kinder, more psychologically safe workplaces, teams, organizations, systems of care, that also leads to more joy in work and greater compassion and understanding and empathy. And you follow the work that many people, I've talked about it already, have done around it. that's going to lead to improved patient and population outcomes. So this is a really key leadership challenge for us, and we need to get very serious about it. Now, at Imperial, the Imperial College Healthcare, we're one of the biggest NHS trusts in the country. And I think fair to say, when I first joined, and I was sort of originally put as a placement as a trainee paediatrician about 15, 16 years ago, and then actually really loved the paediatric department and stayed, but our wider organisation was really poor on this. It was, I think, a somewhat arrogant organisation, sort of slightly, you know, that sort of old teaching hospital, you know, some great care being done, some wonderful people there, but organisationally wasn't really focused on people, wasn't very smart on this agenda. And a number of us actually started to really stand up and say, look, this needs to change. And we have really focused on this idea of vision, being really clear about what you want to be and do as an organisation, and how you behave. So what you stand for and how you behave really follows that through. And we did work with about 2,500 staff to say, look, what's important to you about who we are as an organisation, how we behave, how we work. And they came up with these 4 values around being kind, being collaborative, being expert in what we do, and really trying to be aspirational. And that built in a whole piece about learning and discovery. And it's a fantastic organisation for sort of research and innovation as a result. Now, this is a great example of getting things wrong. I was really convinced that we did not need to do this at all. And it was a weird, strange thing to do. But others who are smarter than me won out the argument and said, look, we need to codify and write down what we mean by kind behaviours. And so these are some examples. And what a lot of staff and, you know, people more junior to me have said is, by being clear about this, it has helped them to challenge people, to feed back to people, to role model better. So the specific and explicit, these are things we'd love to see, these are things we absolutely expect to see, and these things that we don't want to see, almost set out a set of standards. So as I say, my view on it was I wouldn't have gone down this route, but I think you know, I was wrong on that, and it's been a really helpful tool, particularly for people who perhaps find it harder than some noisy doctor like me to stand up to some of this. Final bit from me, and then we'll open it up to some questions and discussion. I want to talk about our conversation for kindness. So this is another final gorgeous story really that comes, and the group of people mentioned in the box at the bottom, just huge thanks to them. And these guys are really close friends really through this journey we've been on together. So about 2.5 years ago, I was really picking up a head of steam around this work, and put in to run a workshop at the next big Institute for Healthcare Improvement BMJ conference. And that all got moved to virtual because of COVID. And this group of us were just doing a planning workshop, a planning conversation, planning call for this workshop. And this was around 2 and a bit years ago. And we put a couple of these in before, and it was November 2020 was when this workshop was meant to be. And we said to each other, well, what would be a really good outcome from this workshop? And I said in a sort of gentle way, really, look, you know, I've just loved working with you on designing this workshop, and we've used these monthly meetings for a couple of months in the run up to the workshop. I'd love to keep meeting with you all. Why don't we just open it up and see what happens? And anyone who comes to the workshop can come and join these calls if they want. And so really that was it. And we just tried it as a little sort of test of change to see what would happen. And it's gone completely crazy. And we've now had contributors from 29 different countries. And we meet monthly on the 3rd Thursday of the month at 6 o'clock UK time. That doesn't correspond into a very sociable time for you lovely friends and people in the Southern Hemisphere. Nevertheless, we get absolutely crazy people dialing in from Melbourne and Sydney and Auckland and Singapore and others in the middle of the night. And I I was saying to Anne earlier, I sort of plead with people, please go to bed. But they seem to keep coming back for more. We've got much better actually at recording the sessions and things. And so they're now available on a website, which is called kindnessinhealthcare.world. And we've got another of these tonight. So I'm starting my day, or near the beginning of the day, with you now, and near the end of the day, hosting our conversation, which is this evening. Final really bit from me is 22 months into the conversation, what have we been learning? Well, there's some really hard edge stuff in here. So just, if you've popped off for a coffee, or you're getting to the end of a long day, really tune into some of this, because I think there's some heavyweight stuff in here. So let's start really hard and clear. Kindness is a choice of action. Okay, so it's an action, and it is our choice about how we act. And we can all take and role model and lead for. So this is about being deliberate, and you can start to see the corollary where people are behaving in an unkind way. That is also a choice. So let's be really clear about this, about action. This is about a choice. Now, there's some really interesting stuff in the second bit. What's more important, a kind intent or the outcome of kindness? So those of you ethics scholars and philosophical scholars on the call will love to sort of get into some of that, and I don't know the answer, but it's, I think, a really interesting thing to explore. There is definitely a growing evidence of the biological and psychological impact of kindness. There's some amazing people who've come and got in touch in and around that. And more work is needed to evidence the direct impact of kindness on quality and safety and equity. Our call this evening is with new friends from the University of Sussex. There's a professor called Robin Banerjee who's led work around kindness. It was featured, it was a big population level work that was strongly featured on BBC Radio 4. And they're coming to present some of their early results tonight. So I'll be learning more about that. And really critical that leading with kindness needs to be central in the work to reduce staff burnout. So I find it totally extraordinary that it took a global pandemic of once in a century proportions to come along and make healthcare leaders realise that the health and well-being of staff was paramount to looking after patients. I personally think it's just totally extraordinary. And I think it's been leadership failure. And for the record, I've been a leader in the healthcare system for a while, so I'm in on that as well. But we have to get real about how we look after our staff, and the leadership around kindness is key. Now, fundamentally important to that is systematically challenging unkindness is a crucial role around this. So I am very, very tough on this. And my big question, and we'll touch on this later, is what are you prepared to walk past? So I have a very, very, very clear focus in my mind. I do not care how important you think you are, I will absolutely take you on about unkind behaviours, and that starts right at the very top. I have not met our new Prime Minister in this country, but I would absolutely be very comfortable in having a conversation. Just importantly, in hopping back to being the doctor again, where I've seen unkind behaviour, and I'm talking about in consultant colleagues or executives or others, and they get hauled in to come and sit down with me, there's almost always some sort of diagnosis underneath it. There's something going on in their lives. So I deeply believe there's very, very few evil people in the world. Most unkind behaviour comes from issues around self-esteem, difficult things going on at home, people feeling scared, people having made a mistake, lots of worry, and there are interventions and support that can be put in. So there's a very hard edge that the behaviour is unacceptable, and I'm really, really tough on that. But then we need to support and be kind and try and understand what's going on. That is absolutely critical. Now, I also accept that as a 6'3" white male doctor executive who's been doing a load of work in this, who's connecting with people across the globe, I'm in a strong position to stand up and be really bold on this. And whatever level you're at, that's going to be different. So we get into some really interesting discussions around this sort of active bystander piece, but really trying to encourage people. And one of the interesting things is creating a sense of jeopardy around this stuff. So there are a significant number of us who are healthcare leaders in different parts of the globe who are really standing up on this and are very determined that our healthcare system is going to change on this stuff. And there's a piece for people about which side of the argument do you want to end up on. So this is, if I do one thing in the rest of my career, it's going to be focused on that. So this lovely thing on a more positive asset base is kindness is this wonderful cycle. Being kind stimulates more kindness. Go and test it, try it. Just hold a door open for somebody or smile at somebody. Just see what happens. And you get this beautiful ripple effect. Small acts of kindness can have a big impact. And I think the final bit is the one to leave you with is, if you make kindness your starting point, then everything else follows. I've got my email there. If you want to join the conversation, what happens is I'll just send you the Outlook invite. It sits in your diary on a once-a-month basis. I send one email a month that just reminds everybody what's on, and you're very welcome. It's a rubbish time of day for you guys in the Southern Hemisphere. There is a growing cadre of Southern Hemisphere friends and colleagues, and a wonderful colleague who I've never met in person. One day I'll get out on a plane and come and see, called Nikki Macklin. It's been really helping to sort of convene things, and Nikki's based in New Zealand, and again I can connect you up. So any of you who get in touch with me, I'll loop you back into Nikki, and I think there's some interesting opportunities to do some things in the Southern Hemisphere too. Final bit, what does this mean in practice? So I just want you to leave you with these three things. And this is really where talking to colleagues working in healthcare around things. And when I hear say, what am I going to do? This is not what am I, Bob, going to do? This is, as you're listening, what am I going to do? So what am I going to do to increase the focus on kindness and to reconnect myself and my colleagues with the real mission in healthcare? The second question is, when I see unkind behaviours, what am I prepared to walk past and ignore? And on a more sort of positive base, what are the kindness always events? We talk about never events, but what are the always events I can promote in my leadership of high quality, safe, equitable care? Right, listen, plenty enough from me. I'm going to stop sharing, and we'll have a good go at trying to get on into some of the questions and things as well.
Sorry, Bob. We can't. We can hear you. Can you see us?
We can see you, and the questions are starting to come in on the Q&A bit of the chat. So yeah, I can see you, I can hear you. So all feels good at my end.
And for some unknown reason, we can't see the chat.
So have a little look. It seems like Anthony's put a helpful message and said the chat is disabled. So, but it looks like people are successfully putting questions into the question and answer. So have a click on the question and answer. And those of you listening, if you put them in on the Q&A, and we'll do our best to work through them.
Excellent. I hope everybody online can hear us and see us now, because for a minute we couldn't get back in. So, Bob, thank you ever so much. That was absolutely fantastic. And I'm sure everyone online thought so. And I think there are a deluge of questions starting to appear. So perhaps we could just begin with some of the questions from those who are online. So Sarah Cole, who's one of our RACS counsellors, and I'm not sure if you can see this question, Bob, how do we protect patients better from organisational unkindness, systemic unkindness? I find myself being unkind about long waiting lists.
Yeah, it's such a good question, and it, the context of what's going on at the moment, I'm sure, I don't know the detail of your healthcare system, but I'm enough globally read to sort of recognise that every healthcare system in the globe is creaking under the pressures of demand and the issues and pressures on the workforce at the moment. And it's really, I'm going to give you an example actually that links on into equity. I think we've got to get back to that place around real humanity, and your question inherently tells me you're right on this already, is the waiting list that can very, superficially feel like just a list of people and numbers, or a list of sort of numbers and names, is real people with anxiety, waiting for a diagnosis, feeling anxious, feeling scared, potentially getting worse. And I think we have to, as we move towards a healthcare system that's more focused on genuine population health, we have to think very differently about it. So I'm going to give you my confession related to did not attend. So I suspect, like all of you, you get very overbooked and busy clinics. And when a patient does not attend, in my clinic, and maybe in this overbooked clinic, 3 patients do not attend. My sort of historic thinking was, thank goodness those 3 did not attend, because otherwise I'd have fallen over and not coped with the size of my clinic. But we started to look at some data and understanding some really significant equity issues. So in our part of London, if you come from a Black community, you're 50% more likely not to attend an appointment. And if you come from the most deprived quintile, you're 55% more likely not to attend to an appointment. And if you think about a consultant appointment as being actually a really key gateway as access to healthcare, you start to get yourself in a real equity problem there. So I've started to go on a bit of a mid-career, a sort of mental journey to worry much more about those sort of did not attend, that from a previously sort of selfish reasons would think, goodness, that's my way to survive the clinic, to actually think we've got to really start tackling this in a very different way. So to your question, Sarah, I'm trying to think much more about genuine pathways and populations. People on a waiting list are people we have responsibility for. Are there some things we can do in the way we communicate with them, in support and help we offer them whilst they're waiting? We clearly can't suddenly magically get rid of all these waiting lists because we don't have the resource to try and do it. But my attitudes and approaches to that, and this lens of equity, I think is really key. So one piece to go and have a look at is think of that waiting list through a lens of equity, through ethnicity, through deprivation, and see where that opens up. But I think you've opened up a really critical question that's going to dominate how we think about good healthcare over the next decade or so.
Thanks very much. Can I also go to Stuart Proper's question, which I'll try to paraphrase, but I think it's an interesting take and on something that we probably all see a little bit of. So Stuart says, I love the rational and the relation lexicons. It would seem, however, that the rational involves deliberately unemotive punitive measures, whilst the relational involves goes around empathy and understanding. The first perhaps refers much more to how we clinicians might see bureaucrats and administrators, and the other perhaps refers to how we involve ourselves with colleagues and friends. And then his question is, do we really need to do the right thing because we're fearful of the punishment or the backlash, or should we be doing the right thing because it makes us feel good?
It's a brilliant question, Stuart. Listen, you've sort of summarised Julia Unwin's brilliant work in a very succinct question. So well done, you. And it does bring up a really interesting question and point. So my sort of philosophy on life and who I am, and I'm sure I exhaust people who are around me by a general sort of sense of optimism and energy and enthusiasm. So I'm definitely much more of the feeling that we need to be on your sort of more carrot than stick. We need to be absolutely encouraging, and I would like a much heavier dose of the relational than the rational, if I'm really honest around it. However, I think 2 comments I would make. One is, when I look at that, in some ways, I'm a bureaucrat and a manager as well as being a clinician. I'm, one of the exec directors responsible for how we run our organisation. And I think the more we can do to depolarize it, just look across the globe. I mean, whether you take Trump or, what we've had in the UK, I know a little bit about Australian politics and stuff, just we head to this polarized piece the whole time. And I guess, to me, often the answers are somewhere in the middle. So I think, patients do need, we've had some scandals in the UK that, good regulation, and scrutiny can have real value to. So my inclination is that we definitely need both, and we need a combination of them. The key point is at the minute we have a dose of sort of 20 of the blue, the rational, and only 1 of the relational, and we've got to get to a balance. So it is going to require a real tip. And I had a really interesting discussion with a very senior colleague in the NHS about a couple of years ago, about the sort of the hard edge piece and the stick around it. And my take is I do think we need a little bit of that around stuff. So, you know, I now on recruitment basis will put these sorts of behaviors as absolutely key. So if you want to come and work as part of my team, how you behave and your attitudes towards it, if you cannot demonstrate that very, very clearly, you're not going to end up working in my team. And interesting, very hard to do in the National Health Service, but if people persistently behave poorly and you know, reject the support that people try and put around them, they need to be kicked out and moved on, in my opinion. We have to put a hard edge in on this, you know, a really serious hard edge on it, and I'm very determined about it. So I'm 90%, let's be very encouraging, role modeling, asset based, but let's be very, very clear about the steely piece on it. And Irving will come on in on this. We talked, and with it was one of my wonderful memories, talk with UK surgeons about this, is, you know, if you are a technically brilliant surgeon but fundamentally unkind and create an environment that is not psychologically safe, are you a brilliant surgeon? I'm totally clear in my head that you're not. Okay, you can absolutely and have to take on both. We of course want technically brilliant surgeons, but we want people who deeply understand that creating a psychologically safe environment for your colleagues and for your patients is really, really critical around that. So, you know, please come and disagree with me. I love to get in a good scrap about that, and you can tell me what do I know of the paediatrician, but I'm really, really serious about that. And it was a wonderful, we had a fantastic discussion with the UK guys about that. So there you go. I've loved a provocation and to get everyone fired up.
Thank you. Sounds to me like many of you may know Chicago Med, the US-based kind of series, and a particular practitioner in that clearly has difficulty with kindness and empathy, and is probably on the autism spectrum. But it's interesting to look at how that character interacts with others and how he goes through a learning process. There's another interesting question here that I think many of us have experienced in one form or another, either on the receiving end or the sending end of a patient. Bruce Waxman says, "Hi Bob, my interest is in encouraging doctors to be kind to each other, especially when transferring patients between health services and handover. Your thoughts about how we might change some quite ingrained behaviours in that area?"
So listen, thank you. Bruce, hello. What a brilliant question. If I had spare time to do a few more PhDs and things, I'd be heading into this territory. I think it's absolutely fascinating. So Anne, here's a reflection for you on it. So listen, hand over the handoffs between professionals, the gaps between primary and secondary care, they are persistently where patients fall in and have rubbish experience, and indeed that impacts on outcomes. So we know the risks around it in terms of experience and outcomes. I understand a sort of protective mechanism that we have around tribes, and lots of people have written about this, not just in healthcare, but for smart people, so, you know, healthcare and doctors, we collect smart people. We are completely stupid about this whole approach. We spend our time rubbishing other people, and we do it all the time. Okay, you know, my lot on the medicals, oh, the blooming surgeons, ... Okay, or, you know, oh, the GPs, ... or, you know, the wretched nurses, ... or the people who work in the hospital down the road. You just notice it around you. Wherever you're working, you will be being rude, and your teams will be being rude about the team in A&E or the general practice or the hospital down the road around things. Now, there's a bit of the sort of survival piece on it. There's a bit of sort of medical dark humor that I think has a history to it, and all of that's sort of interesting. Quite fundamentally, though, what we're describing is A, counterproductive, It's B, just rubbish psychology. Even if you thought it was true, even if I thought that the guys in A&E were a bunch of lazy layabouts and weren't, it's just rubbish psychology behaving in that way. So we have to just get over ourselves. We have to really try and think about the counterproductive nature about this, and we have to recognize. So I think there's two steps. One is recognize exactly as you said in your brilliant question, these handovers, these handoffs are high areas of risk. And then we've just got to park our egos and park all of the sort of tribal bit of, oh, my bit's better than your bit, and just grow up and think really, really carefully around how you need to big people up. So I spend a lot of time bigging other people up. And my single biggest area that I'll pick on is around the relationship between hospitals and general practice. So my pediatric practice, my outpatient pediatric practice, is not done in outpatients anymore. All of it is done out in general practice. We've got a wonderful program called Connecting Care for Children. Do look it up. If you've got friends and colleagues who are pediatricians, I'm very happy to talk more about it. So yesterday I was out in a GP practice in the north of Kensington, sat with a GP. We ran a multidisciplinary team meeting where we had mental health practitioners, dietitians. We talked through a whole lot of patients, and then we saw a number of patients together. Fundamentally, it's about the relational bit that Julia Unwin was talking about: building trust, building relationships, swapping phone numbers, keeping in touch. I have now sat in with about 160 GPs across our local patch. So I reckon about 2/3 of the GPs in our local area know me and I know them. So a patient comes into the emergency department, gets admitted under my care. I say, who's your GP? More likely than not, I'll know their GP really well. And I'll talk them up and say, they're wonderful. I saw them a month ago, you know, and the patients look and think, oh my goodness, we've got a connected care group just based on relationships. So it's that trust and relationships bit. The question is a brilliant one. If you go and do one thing on this, honestly, start bigging other people up. You'll feel better about it as well. And it's all about our own self-esteem and egos and things. Just park that for a bit, build some other people up, and you'll have some fun.
Thank you. And perhaps a final question that touches, Bob, on your comment that often unkind behaviours stem from other things that are impacting that individual's life. And I guess there are two questions that I can read in front of me. One that says a statement which is a standard leadership statement, really, which is to lead, you have to understand yourself, both your good and your less good attributes. And that's followed by a second question saying that often substance abuse, but other things like burnout, etc., can lead to unkind attitudes. And how do we assess those situations? And how do we build resilience in ourselves and others that allows us to maintain kindness?
Yeah, thanks, Anne, so much. And actually, I'd almost weave in that third question from Stuart Fleming as well about being firm on boundaries and kind to the individual. I mean, look, you know, it's a joy being here with you because all three of those questions, I think, are right on the money and really pick things up. So I think I touched on it when I talked about our learning today, Tiz. And I think this is such an important piece, so yes, we've got to get, you know, the talk, this is about kindness being the business end of healthcare. It's where things start. We have to be really clear about what the boundaries are on it. However, we've got to be curious and thoughtful and kind in the way we behave and react to unkind behavior. And I touched on it earlier, and almost always there is actually a reasonably easy to access inverted commas diagnosis. Is maybe not, I can speak to a bunch of doctors about a diagnosis, but something going on for people. And it's really interesting. I think I sat with an ENT surgeon about a year and a half ago, and I got, unfortunately for him, no, fortunately for him, because it actually helped in the long run, I got copied into a whole sort of grim set of reply all emails, and there's another reply all email. What a dreadful tool that is. Anyway, I was copied in. There were some awful behaviours on email, and I wrote a reply as a senior chap focused on it. It was about clinical care, and I was involved in the clinical care. And I wrote on Reply All, which I don't do, "This is neither kind nor helpful. Here's my telephone number." It's what I think my teenagers would call a sort of mic drop moment. Apparently, it went very viral on the ENT WhatsApp group of like, "Oh my goodness, who is this guy? What's that?" So I phoned up this guy phoned up me. He didn't really have any choice and was quite defensive. And I said, "Look, let's speak on Monday. I can find some time. Come in and have a coffee." We sat down. The first half an hour was really defensive, and I don't care how long it takes to sit here. We'll just keep sitting here and chat away. And the layers started to peel away, and the guy burst into tears, and there was all sorts of just openness about how difficult things were and what was going on in his life and his work, and what the pressure and the stress, and that had manifested itself. And people then get stuck in a hole. They find it hard to apologize and back off. So this sort of ultimately relatively trivial thing that had slightly spiraled out of control, and I could see having big impact on people and patients, has a diagnosis around it. And actually, this is a wonderful, kind, trying to do his best surgeon who just got himself stuck and in a difficult place around things. And we've got to look after people. And healthcare is a really tough business. We all go into it, for amazing reasons, but it's difficult. We have difficult things we have to deal with. And I think we have to get much more compassionate to ourselves and to each other, and the way we support each other. And that goes back to my sort of anger, really, about how healthcare leaders, and as I say, it's not me blaming others, it's about me saying I'm part of this. I think we have to label this as leadership failure of the last 10, 15 years or so. And listen, I'm afraid we're all in on this. And the more of us who are pretty senior who can say we have really failed on this and we need to pivot and shift, I think the more honesty and humility that a number of us can show around this will enable and encourage these young, I spend lots of time with medical students and as a paediatrician and the age of my kids with young people that are thinking about careers in care. We have to demonstrate that the future of healthcare is going to be a fundamentally different place. I'm absolutely determined by that. And if I can have any help from everyone on this call, that would be amazing.
Thank you, Bob. I think we've been treated to something spectacular, fascinating, and very thought-provoking this morning and this evening, wherever you may be in the world. Bob, first, I'd very, very much like to thank you on behalf of everybody on the line and on behalf of the Senior Surgeon Section of the RACS. It's been an absolute privilege to listen to you, and I think we'll all go away and look at this aspect, a very large aspect of our practice of healthcare and our leadership in healthcare in a different way. So thank you, and I expect you'll receive lots of connections after this as well. So thank you ever so much.
Thank you.
Irving,
thanks for having me.
It's a pleasure. Irving, thank you ever so much to you and your team and to the RCSE for supporting us in setting up this endeavour and for joining me today. And I hope that this is the beginning of an ongoing connection between our two colleges. So thank you. And last but by no means least, I'd like to thank Alan Shirley, who is really the person who's brought this idea to fruition. Alan, it was a fantastic idea, and your hard work, I think, has paid off. And we're now at the start of something that hopefully will be very enjoyable, not just for the senior fellows within our college, but for all fellows and trainees. So on behalf of us, thank you very much indeed. And everybody, thank you for joining us tonight. And finally, to my Australian and New Zealand colleagues, may the best team win in an hour or so. Good night, everybody, and thank you again.
Thank you.
Good night, everyone.
Thank you.